Hello, everybody. This is Louise Gittleman. I'm here with you for the First Lady of Nutrition podcast, and I've got some very special guests whom I know personally and have had some wonderful, wonderful results with. I'm here with Larry Wurn, who's the CEO of Clear Passage, and his beautiful wife, Belinda. And together they co-developed the Wurn technique and Clear Passage approach, which is a non-surgical treatment for pain, female infertility, bowel obstruction, and sexual dysfunction. So good day, my friends, and how are you this day?
Hi, Louise. It's great to hear your voice. We're hanging in here.
You sound good. You sound good, dear.
Well, that's a good thing. Now, tell me a little bit about your journey. Belinda, maybe we should start with you. You are a physical therapist, but you are on your way to becoming a MD, if I'm not mistaken. You were very, very interested in medicine in your earlier days. What changed you into a physical therapist?
Well, actually, it's a funny story. My boyfriend at the time was in medical school, and I saw how many hours a week he had to put in and being on call every third night. And in doing realistic self-assessment, I don't make good decisions when I'm tired. And going 24 hours with no sleep just didn't seem like it was a good idea for me. So I looked into physical therapy, and it sounded like, a wonderful medically related profession. So I changed majors, and it took 6 years to get my bachelor's, but I was happy about that.
And how did you meet Larry, who is your life partner at this point? You two have been married 30 years-ish?
32, May 30th. Yeah. We actually are distant cousins, and I was born in Havana, Cuba. And my in-laws, Larry's parents and grandparents, helped my parents and me move to Jacksonville, Florida when I was 2 months old, and Larry was 3 years old. So I've literally known him all my life except for 2 months.
What a story.
Yeah. So, I graduated from PT school in 1975, and I got straight A's all through PT school. And in 1984, I developed cervical cancer.
Oh, my goodness.
By the time they found the cancer, it had spread from my cervix back toward my rectum. So they were very aggressive with me with radiation. So I had to go 5 days a week for 8 weeks for 40 external treatments, and that shrank the tumor by half, the radiation. And then I had to have 2 internal radiation treatments where they put these radium pellets in the stainless steel tube and surgically implanted it in my uterus. And I had to lie still in a lead-lined room for 72 hours, and I had to have 2 of those 2 weeks apart. So it killed the cancer, but destroyed my ovarian function, so it threw me into menopause at 33. And I developed what's called a frozen pelvis, where all my organs were glued together from adhesions, which are internal scar tissue, that formed from the radiation. So, as well as I did in PT school, I didn't know what to do to get myself out of pain. So that started me searching for alternative answers to treating pain caused by adhesions.
And how did Larry come into the picture? Larry, you were not trained as a physical therapist originally. Tell me a little bit about your background and how you came to work with your beloved Belinda.
No, Belinda and I grew up together as childhood friends. We weren't really sweethearts. We were just buddies. I mean, when I was 10, she was 7. We would play together on the weekends and things like that. And I married and went to California for a while, where I married not Belinda, and became guest curator at the Fine Arts Museums of San Francisco. Did huge shows for the city of San Francisco and all of Marin County and Oakland, and kind of joined all the museums together in a show that took about 3 years to put together. It was very large. We were in Rolling Stone on the cover of the San Francisco Examiner. It was big. I was young. I was only 23. I didn't know you couldn't do that then, so we just did that. And meanwhile, Belinda at the same time had married, and she moved to South Florida. And both of us, for me, my wife and I, at the time, she was an actress, people started treating us both like stars. And at 20, 23 years old, everybody treats you like you're a star. It was hard to hold a relationship together. She got offered a job in films in LA. I stayed in San Francisco doing this big show. So she and I divorced simultaneously. I didn't know it. Belinda had been married and got a divorce, and we ran into each other when we were both in our 30s. And I said, "Wow, you turned out really neat." She said, "Wow, so did you." We're distant cousins. Do you think it's okay to, we kind of date? And we talked to the parents, and they said, "Oh yeah, you're so far." We looked at it all. They said, "You're so far distant. It's all right." And of course, I've just loved this person since we were kids together. And she's this beautiful, brilliant woman, much smarter than I think. But as we were planning to get married, is when they said, "Well, we're going to put you in this lead-lined room. It's dangerous for us to be in there for more than 5 minutes at a time," the nurses said when Belinda had this radium implanted in her. "But we're going to keep you there for 72 hours, and we're going to do that twice." So it was a nightmare, her going first through the cancer, then the treatment, which was awful as far as the ramifications, because a year after she was treated, Ann Louise, she couldn't walk, move, or breathe without pain. It was so horrible.
Horrific.
It was terrible.
Yeah, I couldn't work for almost 3 years.
Seeing somebody that I love so much in that much pain, as I said, we have to find a way to treat these adhesions. Her doctors didn't want to do surgery. They said, "That's right by your vagina. We're going to create more adhesions. It'll be worse if you have surgery. You'll just have to learn to live with the pain."
Yeah, so I started, I must have seen at least 6, if not 7 or 8 different kind of doctor specialists. And I got really tired of hearing your pain is all in your head, or you have to learn to live with it. And at 33, that was not acceptable. So I started traveling all over the country, getting treated by therapists that did different kinds of hands-on work that I would read about in the 2 weekly physical therapy publications. And anyone that helped me, I started studying what they did. And then Larry got tired of me traveling so often, so he studied with the same people and ended up going to massage school. And he kept treating me and got me out of pain and ready to go back to work full time. So that's when we opened our first private practice in 1989, treating people with complex, head to toe pain, headaches, neck pain, back pain, pelvic pain.
So I wouldn't be wrong in saying that you're actually a pain clinic, a non-toxic. So you offer non-toxic solutions to pain, acute and chronic pain.
That's correct. I mean, the thing is about adhesions, these internal scars, they form anywhere tissue has been damaged. Anywhere you've had an infection or a surgery is a major cause of adhesions, inflammation or an injury, the trauma, the surgery, these internal scars form. Then once you've healed, those internal scars remain. They're estimated at about 2,000 pounds a square inch. So, but they don't show up on X-ray or MRI or CT scan. So we were seeing people with pain that are saying, "I know I've got this pain here in my side or my hip or my groin or wherever." And I go to my doctor and he says, "There's nothing there," or "I can't see it," or "Maybe you should see a psychiatrist. I mean, there's just nothing there." But inside you're being squeezed by these straitjackets of this glue-like substance that the body produces naturally. Adhesions, composed of collagen cross-links, little strands like strands of a nylon rope, but they form and the body just does not have a way to get rid of them. So that was our challenge, to get rid of those in Belinda.
Yeah, and the thing about adhesions is they're made up of soft tissue, and soft tissue areas where there are problems don't show up on any radiologic diagnostic test. Those tests show up solid things, more solid things like tumors or cysts or fibroids. But when we look at a patient's history, if they've had any surgery, if they've had any trauma, and we look at lifetime trauma, it's cumulative. Falling off your bike as a kid, falling off of a horse, car accidents, even fender benders. the body lays down adhesions as a natural part of the healing process. And the way the adhesions form is sort of like a spider web. So they not only form to help the area that was cut or injured heal, they can and do start sticking to anything and everything in the vicinity that can cause pain, you know, up into the head, down into the buttocks, into the legs. I mean, you know, the adhesions run in many different directions.
So I have a question. These form as a result, you said infection, if somebody had an infection, if somebody had a surgery or some kind of accident, and what about repetitive postural movements? I'm thinking of those of us that text all the time, that are on the computer with that text neck and are slumping over. Do you see a lot more adhesions with people that are sedentary and at the computer in this day and time?
We do. I mean, the thing is that as we're raised and from the time we're in school, built over our school books and our desks and now computers, we're in a flex position. That is, our shoulders and head are forward rather than standing up straight like we would be if we were hunter-gatherers. So those chronic positions over time can, we believe, cause adhesions on the front of our body. And as you grow, it starts to, as they're pulling, your back and neck are fighting to get you to stand up straight, and you just can't because you're being pulled forward by these 2,000-pound square inch bonds. So now I start to develop neck pain, back pain. Now I've got headaches because I have to look forward and it kind of squeezes at the back of my neck, the base of my skull. That's the place that we generally, a major place for unlocking migraine headaches for our patients. So did that, and of course, if you've had any sort of surgery, a burst appendix or C-section, any of the things that Belinda mentioned, it pulls you forward further.
So here's my question to you. How would one know when I know these wonderful practitioners, to my listening audience personally, because I've had experience at their very, very fine healing clinic. When I came to see you, I had no idea that my issue, my pain, was caused by adhesions. And I dare say many individuals, Larry and Belinda, don't know the etiology of the source of their pain. It's probably redundant what I just said. My point being is the underlying cause may be, in fact, adhesions or internal scar tissue. So how would one know if, in fact, adhesions are at play in their health condition?
Well, again, you know, they have to think about their own medical history. Have they had a bad fall, fallen down a flight of steps, tripped and fallen over a dog, you know, any kind of an injury like that, you know, even though, you know, people say, well, it wasn't major, I didn't have to go to the hospital or anything, doesn't matter. They still formed, their bodies still formed adhesions. So, I mean, if people aren't sure, you know, we're happy to offer free 30-minute phone consultations where either I or one of our other physical therapists review their filled out medical history form, and we can definitely give them more accurate answers as to if we think that adhesions are most probably what's causing their pain and different kinds of symptoms.
So your technique, which you call and it's a patented technique, would you describe what that involves? If someone were to come to you, for example, and I know you have clinics and satellite clinics all over the country and in Europe, if I'm not mistaken.
True.
So if somebody were to come to you or one of your satellite clinics, give our listeners a sense of what that treatment would consist of, what you actually do to release, because you have a special sauce, and I'm not asking you to kind of release the sauce to my listeners, but you have a very unique way of combining the best of osteopathy and trigger point therapy and myofascial release and something very unique, which is the Wurn technique. But give them a sense of what you do with a patient that comes to see you that has pain, for example, in the upper neck.
Okay, the first thing, well, first of all, Anne Louise, you need to know, and your audience needs to know, If we think we can help, we'll say so. If we don't think we can help, or we think there's a potential that there would be problems, we're going to say so. So we're not trying to sell anything or just bring people in. We want to have people come in who we feel are appropriate and we feel we can help. So before anyone even comes in, we will send them a referral checklist for their physician to go over to rule out any contraindications or any concerns that we would have or their physician would have about receiving deep soft tissue work anywhere in their body. We'll go over that and review. If we have any questions, we'll call them and or their physician or physicians to make sure that they're safe to come in. Once a person has been accepted for therapy, we're glad to have a conversation with them and see if it makes sense to them, let them know if it makes sense to us. When you come in, generally speaking, we had a gentleman from a PhD from one of the research directors at the National Institutes of Health actually moved into town here to study us when his son, who was a radiologist, started seeing some remarkable results from what we were doing. And his son called, "Hey, Dad, up at NIH, you got to look at what these people are doing." The guy came down and studied us, and he said, "Well, you at that point we were opening blocked fallopian tubes, which has never been done without surgery, and now we've opened hundreds of them." Published recently a 10-year study of 1,392 infertile women we treated. But I asked Dr. Wickman, I said, "How many hours does it take to achieve results?" And he said, well, he looked at all of our data and examined it, and he said it takes 16.2 hours to open blocked fallopian tubes. That's a really good gauge because we can do films before and after and see if you actually decreased adhesions enough to open these tiny little structures that are designed to carry a single cell, an egg, and a few sperm, which are much smaller than an egg. Something we guys don't like to talk about. But anyway, he said 16.2 hours. And we had people applying to us from all over the world, really, by this time. So we designed a 20-hour program. So to get to the answer of your question, once we clear you and make sure that we think we're going to have good success with you and you understand it, you come in and most people fly in on the weekend. They come in on Monday morning. We'll see them for 2 hours Monday morning and 2 straight hours Monday afternoon. And the same thing Tuesday, Wednesday, Thursday, and Friday. At the end of Friday, they're just discharged. The first Monday morning, that first 2 hours consists of about an hour and a half of really a very thorough evaluation. And then in some of our clinics, like in Gainesville, where our headquarters is, we all discuss this patient every single break. We take a break at an hour. We go and talk to the next therapist. There are about 3 of us that are treating at a time because we just handpick therapists. We don't want just anybody, which is probably why we're so particular. And by Friday afternoon, they're discharged. Along, we're giving them an education in adhesions so that we create the vision in the beginning and request the patient to be, as much as she or he would like to be, an active member of the treatment team. We educate them about adhesions, how they form, what we're doing to deform and detach them, and give them a tool and have them visualize walking out at the end of the day on Friday with exactly the body they came here for, including leaving behind all the stuff that is not serving them anymore, any of the anger and the frustration, the why me, so that, and with a real understanding of not only having gotten a new body, no longer bound by all these 2,000-pound square inch crosslinks, but with a knowledge of what's going on so that they know better than their physician, who has said, if their physician said to them, "I don't see anything," or "there's nothing there," they now understand what that was and how to deal with it themselves. If they need to come back, they can come back, but only, I think, maybe 12% of people come back.
So when you start the treatment, and I've experienced it, so I know firsthand what you're speaking of, How does it feel when you're removing adhesions? Adhesions are 2,000 pounds per inch in strength. So when people feel certain sensations, how do you know your treatment is working? Can you actually feel the adhesion detached with your skilled fingers?
Well, we feel for tissues, and we check for the mobility of, like, all the organs should be able to slide and glide over and around each other as they function, but also as you do all your daily activities. So, you know, when things become adhered, organs and soft tissues, it's very palpable. And, you know, our hands we've been doing this for over 30 years. So we feel for areas that feel thick or lumpy or tender or hard. Anywhere in the body should feel soft. So we check organs, and we check the soft tissues throughout the whole body. I mean, we treat the whole body because everything is connected through our connective tissue, the fascia. If you could picture being knit like a sweater, this fascia runs from head to toe and front to back, and it surrounds, supports, and separates everything in the body. So with our hands, we'll, you know, wherever we feel a tight area or a thick or lumpy area, we'll put those tissues on a stretch, and we'll hold the stretch for a prolonged period of time. And like, if you've ever pulled on saltwater taffy, you have this rectangular piece of candy, and you have it in both hands, and you start pulling your hands away from each other. Eventually, if you pull and stretch hard enough and long enough, the taffy will give way and get longer. That's what it feels like to us. You know, what we're doing isn't massage. We don't just rub over things. We are, you know, we need the friction against the adhered areas to get the adhesions to gradually deform and detach and give way. So some of the techniques where things are more adhered, or especially working on surgical scars, some of the techniques can feel like a burny, stretchy, pinchy kind of sensation during the technique.
Yes.
But as you free up, you know, that discomfort goes away. But we totally work within patients' tolerance. We say if 0 is no discomfort and 10 is intolerable, we want them to let us know if we're getting close to a 6 or a 7. So we'll ease the pressure off. It might take a little bit longer, but that's okay, you know.
One of the things that you did when I was there, which I found enlightening to say the least, is that you concentrate on the pelvic floor. Can you tell our listeners why working with the pelvic floor is so important in your complete program and resolution of situations and conditions and illnesses?
Yeah, absolutely. Well, you know, again, everything is connected, interconnected with our fascia, the connective tissue. So the pelvis is the foundation for the rest of the spine. It supports the weight of all the organs, and it supports the spine and the head, neck, shoulders, and the jaw, the TMJs, the jaw joints are sort of like the last link in the chain. So just like you can't, if you have a house on a crooked foundation, you're going to have a lopsided chimney. You know, most of our patients, when they come in, one side of their pelvis is very, very frequently out of alignment, which makes one leg shorter than the other. So that you know, that body is having to compensate all the way up into the head, neck, facial area to keep the body upright with gravity constantly pushing down on us. So we have found that focusing on getting the pelvis balanced and level, the legs even, and then freeing up the adhered areas and gradually working up into the head, neck, and shoulders, you know, many different kinds of symptoms are relieved.
I have one little thing to add to that, Ann Louise, and that is that you gals, you women take better care of yourself, and which means you go to the doctor more often to take care of yourselves. Women, your reproductive organs have things coming in from the outside world. You're much more complex in the pelvis than a man, and you get surgeries more often. let's have the doctor says, well, let's have a look and let's see what's going on in there. You're liable to say, okay, let's do that. Or C-sections, hysterectomies, things like that. Then you have monthly periods, and often endometriosis is fairly common. So for our female patients, you just have a lot more going on that can create a history where adhesions form in the pelvic floor. So
so it's not uncommon.
Right. No, not at all. Especially also if someone's been abused. I mean, physical or sexual abuse is traumatic. It definitely creates adhesions. And, most of the work we do is external, but the internal pelvic work for men and women is invaluable because it allows us direct access to certain structures that we just can't get from the outside. So, it also allows us to free things up from the inside out and the outside in. So it's very three-dimensional. We're not just working on the front of the body. We're not just working on your back.
So this,
we have an expression, treat the symptoms and look elsewhere for the cause, because a lot of times where people are hurting isn't where their main issue and where the main adherent areas are. It's where the body's compensating.
I've heard that expression, the pain is where it ain't, or something like that. And maybe that's not quite the expression, but it's so very true. I found that the pelvic work was really enlightening on so many levels. And I'm wondering also, when you see people, I know that you're world renowned for the work that you do with infertility, but what are other people coming to see you about? Is it mainly infertility?
I'd say about a third of our patients come to us for infertility, for blocked tubes or hormonal issues. About a third are for bowel obstructions and different GI issues, severe constipation, SIBO for sure, small intestinal bacterial overgrowth, and about a third of our patients still come for chronic pain. They've tried everything, been everywhere, and we're sort of like their last hope. And, it's because we treat the whole body that I believe we get the results that we get, and, resolving or at least significantly reducing, headaches, neck pain, back pain, pelvic pain.
If I may, Anne Louise, let me give you about a 3-minute history of how we developed all of this stuff and why we're doing all this.
Sure.
Because it's fascinating. We never really set out to treat a lot of the conditions that we're treating. It's our patients who brought them to us. We first were treating Belinda just because I wanted to get my wife back and get her out of pain. Then when she started treating, she was treating a woman with slip and fall, workers' comp injury. The woman said, gee, I got pregnant, and Belinda said, congratulations. She said, no, you don't understand. I've had blocked fallopian tubes for 7 years. And a physician asked us if we had something to do with that. We said, well, I don't know. We were treating pelvis. So we examined that. He sent his wife, who was 41, had a huge infertility file, endometriosis. She only had one tube, and it had been blocked for 11 years. She gets pregnant. So these women start coming to us for infertility. Meanwhile, women are starting to report to us, gee, I'm having increased sexual function. I'm having orgasms like I've never had before. Belinda said, Larry, what do we do with that? I said, just don't even mention it. We're already the weird practice in town. But
that's all you need.
The chief of staff of the hospital, who's a gynecologist surgeon, hears about that. He said, we need to publish on that and on the blocked fallopian tubes. We do? Yes, we do. So we published on that, and we increased desire, lubrication, orgasm. All these were measurable, and biostatisticians are doing probability, and they're saying, yes, these are significant. You're insignificant in all 6 areas of sexual function. Then decreasing pain is a huge one. That was probably the biggest for intercourse pain. Then a rock and roll singer so we started publishing this rock and roll singer out in California calls up and she said, I read your studies about opening blocked fallopian tubes. Can you open bigger tubes? And I said, what do you mean? She said, Well, I've had 7 surgeries for bowel obstruction where adhesions form in the intestines. It's life-threatening if they don't pass. They have to cut out the part that's bad, hope like heck that nothing spills into the peritoneal cavity, because then it causes a new infection after they close you up. And then that surgery is the cause of another bowel obstruction, and then another one. So she had several bowel obstructions and several surgeries. We said, well, if you want to come in, we'll try clearing these larger tubes, your intestines. So she comes in, bam, we go out, we have dinner with her on a Wednesday night, her first solid meal in about 6 weeks, and she goes home, cancels her surgery, does an in-service for her doctors on this. We started examining and treating and realizing what a huge problem bowel obstructions were, life-threatening problem. It just completed a study authored by a surgeon from Harvard who referred to us quite a few, and then has just since moved to Stanford, and another doctor at Washington University in St. Louis, that shows that we decrease recurring bowel obstructions by 15 times.
Wow.
Then I'm treating these patients, and they're saying, Dr. Seebecker wants to talk to you, or Dr. Sandberg-Lewis wants to talk to you, and I've never heard of either of those, and I kind of didn't want to call out of the blue and say, hey, the patient said I should call. Doctor calls and says, what are you doing with our patients? And I said, what do you mean? And she said, well, you saved this woman's life. And I said, well, I'm glad to hear that. What can you tell me about it? He said, yeah, because she has SIBO, and her physician would give her medications, and the medications would work for a short period of time, but then it would come right back a few days later or a week later. And she had gone from 128 pounds down to 86 pounds and was in a wheelchair when we treated her. All of a sudden, you treated her, and the medications are working. What's up with that? And we said, well, that's great that we saved her life. What is SIBO? Because we didn't. And he flew down from Oregon, and we got him together with the chief of staff of the hospital and a double PhD in histology that we have working with us to understand what we're doing. And we realized that, I said, well, we clear adhesions in the bowel. We determined, well, the medications were working. They were knocking down the SIBO bacteria, but they were reproliferating right away because the patient could not expel them. Once we cleared the adhesions from the bowel, she was able to expel them, and she suddenly could eat again and regained all of her weight, by the way.
Awesome.
So all of these have been kind of surprises, and never set out to treat infertility. We set out to treat chronic pain, and that's still a main focus for us. But the bowel obstructions and the infertility and the sexual function and the dyspareunia, that is the intercourse pain, all of those sort of found us, and patients and doctors said, you have to investigate this. You have to do studies on this. So we started publishing. We've published about a dozen studies now in peer-reviewed journals, but that's how it all happened.
So what I noticed from really perusing your website today before our podcast is that you have published quite a bit, and it's very unusual for body workers to publish so much clinical research. What prompted you to do that?
We got tired of doctors saying, there's no proof that what you do does anything, and then sending us their most complicated patients, the ones that they didn't know what to do with because they couldn't see the adhesions. One of the most recent ones, also co-authored by those 2 physicians I mentioned earlier, showed this woman came in. She was a patient who had Crohn's. She was scheduled for emergency surgery because she had 2 strictures. As you all know, that means a narrowing in her bowel that were causing obstructions. One looked like an hourglass, and in one, and we have films of it, radiographs, and they're on the website, her intestine looks like a coffee straw for about 3 inches. Nothing's going through there. They said, you need to have emergency surgery. She chose to come to us instead. We treated her. She got the radiographs afterwards, the films afterwards, that showed a totally normal bowel. So it's cool. You know, it's been really neat doing science and sort of blending that in here, because we can look people in the eye and say, this is what we know, this is what we don't know, these are our results, here's the data, it's written by independent physicians and biostatisticians and so forth. So that you need that credibility, and you need to know facts, and you need to be able to look people in the eyes and tell them the truth and tell them what you can do, not just anecdotal evidence.
Right.
How do people find out about you?
The people find it, we've designed everything so that people go to our website, which is clearpassage.com. There's nothing salesy about it. It's very educational. You can learn about adhesions. You can look up your condition, see, gee, this makes sense to me, or this doesn't, or why, you know, I have some questions, and call and talk to us. And our staff is trained to listen, and to really listen deeply to what you've got going on, and to answer truthfully and appropriately. And so we try to be a real educational resource for people, rather than trying to sell a technique or a treatment or something like that. That doesn't feel right to us. I mean, people are coming to us for life-threatening conditions, and to have a baby, which is their lifetime dream. You just, and especially after publishing so much research, you just have to just say it straight and just give all the information you can. So we'd send them to clearpassage.com. There's some links there that they can click to get more information, or to fill out a medical history form, something that we can review. We'll send them the checklist for their doctor to review as well. They can talk to their doctor. If their doctor wants to call us, that's fine. But that's pretty much how it happens. And then if they want to come, we say, well, that's fine. Where would you like to go? We have clinics from Southern California to London and Canterbury, England. So can you set aside 5 days? You can come in and see us. So there you go.
And so is there anything, go ahead, Belinda.
No, I was just going to say, even if people don't come to us, we really strongly believe in the importance of educating people about their bodies, so they have a better understanding of what might be causing their issues, and so they'll have more informed questions to ask, you know, their physicians and different therapists that they work with.
Have you written anything for the lay person in that regard?
Yep. Got the latest book. We wrote a 600-page book. That was a little bit too big, I think. So we wrote one called Adhesions. It's available at Amazon. You can actually get it, I think, for 99 cents in a Kindle edition. Otherwise, it's under $10. But it explains all about adhesions in the first 2 or 3 chapters, and then every chapter thereafter goes into specific conditions. I'm writing another one now, a little bit larger. It'll be about 250 pages, I guess, that has study results in it and also some patient stories in it. I'm also, incidentally, going to do a video, because I've had so many questions. How do I know if I have adhesions? I'm going to do a video to show people how they can figure out themselves if this is this adhesions that I have, or is this just I have a 6-pack because I've been working out. So I'll be doing a video for that as well. But the Adhesions is the name of the book, and it's on Amazon or Barnes and Noble, any of those.
So I have a couple more questions if you've got a little time. My questions to you are, for those individuals, and we're speaking during the viral pandemic that's currently taken hold of the world. So I know you're not actively seeing many people at this point in time. However, if people do want to get in touch with you, they'll get in touch through the website, and then they have a consultation to see whether they're an applicable patient or not. Am I correct? Is that the way that goes?
Yes, yeah, exactly.
So for those that can't come to the clinic, what can be done at home for prevention or for treatment? Can you give me any tips, perhaps nutritional tips, or they're anti-inflammatory, certain enzymes, certain essential oils, any tricks of the trade that you might want to pass along to our listeners?
No, I would direct them to Dr. Ann Louise Gittleman. We're not nutritionists. We can't really give much in the way of nutritional advice. Belinda largely created a diet guide for people who are having recurring bowel obstructions, and it's on our website. It's 42 pages. It has inside of there, for example, a chart that says you can see where you are and what you're eating. If you're having problems, I think I'll just go down to this level, or if I'm doing really well, I want to step up a level, I can go to that level. So, but beyond that, we can't tell people what to do with themselves at home, because we're talking about treating in the abdomen and the pelvis, and there's so much that goes on in there. I can't give advice to someone who may have an endometrioma or an abnormal cyst or some other condition that would concern us.
Yeah, or cancer. Yeah.
But I imagine it's safe to say that drinking a lot of water would be important to hydrate properly, taking essential fatty acids, stretching. Do you guys believe in stretching?
Absolutely. Stretching, yoga, and definitely, yes, we encourage all of our patients to drink more water than they normally do, or to start drinking water if they don't. I mean, it's amazing to me how many people just really don't drink water. You know, they drink sodas and tea and coffee. But yeah.
Have you been interviewed by any of the big television magazines? I guess they're, something like a 60 Minutes or a Dateline.
We have not. No, we've been covered by Contemporary OBGYN, which is a journal that goes to every gynecologist and obstetrician in the U.S. and Canada, and Women's World, so a large newspaper just called us from London and wanting to interview us. So I got some patients who had actually flown over from England to us that we treated that did well, and some treated in the UK. But we've not. We're waiting to be discovered.
Yes, you're the world's best kept secret. So what's next on the horizon, Belinda and Larry Wurn? What's next on your bucket list for helping people?
Dare I say it, Parkinson's. We're looking at Parkinson's. We have seen for years, Anne Louise, women came to us with high FSH, that is a hormone that is secreted by the pituitary gland, and when the levels are too high, it indicates that she's approaching menopause. And women were asking us if we could help them with that, because they were refused IVF or they couldn't become pregnant. For years we turned them down because we didn't think we could help, and then this woman came and she was in full menopause. We treated her, she got pregnant. The chief of staff at the hospital said, we'll need to check these pituitary levels. This is a tiny structure in the middle of the brain. I'm coming to the Parkinson's here in a second. You will need to test. Let's see if this was a fluke. Test before and after levels on these women that were infertile due to hormonal levels. Biostatistician said treat at least 8. We treated 16 of them. 6 of them became pregnant before we got a chance to.
Oh my gosh! Oh my gosh! How fun! What a blessing for so many.
Yeah, I know.
And I don't know how many of the others may have gotten pregnant, but just when we checked them right afterwards, 9 of the other 10 improved. And the first woman is now 2 years later, who was supposed to be menopausal. She is now pregnant naturally with her second child, which she had.
Oh my gosh.
So we were talking with a neurosurgeon, and he said, well, wait a minute, if you can help that, can't you help Parkinson's? And I said, what are you talking about? And he said, well, where you're decreasing pressures on that pituitary, that's maybe a ½ inch away from where Parkinson's occurs in the brain. If you're relieving pressure on that, can you do that for Parkinson's? So we're applying for some funding, and we're going to be doing some studies on treating Parkinson's, and we'll see. We're not going to make any claims, but mechanically it makes sense to us. So we're going to just see. That's what's on the horizon.
That's so fascinating. So fascinating. So the age range of the people that you see, is there a particular age range? Do you mostly see females?
No, no. We're about 40% of them, of the patients that we see, are healthcare providers or their spouses or children. Age range runs the gamut from a few months old infants to up in their 80s.
We've seen a few in their 90s. Yeah. But yeah, we see more women than men, but we definitely see men with pain, with bladder issues, bowel obstructions, of course, trauma, sports injuries.
Appendicitis is like endometriosis, which causes inflammation throughout the system and all the interstitial spaces between organs. A burst appendix does the same thing, or a bowel obstruction surgery gone wrong, where a little bit of the contents of the bowel spill into the body cavity before they sew the patient back up. So those things are a huge problem for patients. And doctors don't know what to do, and the doctors and surgeons don't want to go back in there again. They can't always see through the adhesions. They're afraid they may have an inadvertent enterotomy where they cut through something. So those we're very helpful for those patients, like that. So meshes, we don't have any problem treating around meshes.
Or ostomies.
Ostomies. Ileostomies, colostomies, patients with Crohn's, as long as they're not in an active flare, or ulcerative colitis, as long as they're not in an active flare, they do well. Sometimes we'll spread treatment out to 2 weeks for them and just do 2 hours a day instead of 4 hours a day.
You just said something that just sparked another question, if you have a little bit more time.
Sure.
I have a lot of clients that have mesh. Does that create adhesions, particularly in certain areas?
Yeah, well, originally the mesh is intended to help separate one organ from another.
Yes.
But what we find is that like any foreign substance, that mesh often becomes involved in the healing process, and adhesions attached to the mesh. And so now we've got adhesions that are attached to the stomach or the bladder or the peritoneum and the bowel and the mesh in between. So yes, they're often involved in adhesions.
That's kind of what I'm sensing with some of my patients that are in a very, very chronic state of pain. And then the other thing that I'm wondering about, when women have implants and then they have explants, like any kind of surgery, would adhesions be forming in the chest wall?
Oh, absolutely. Absolutely. I mean, again, if you picture the body being knit like a sweater, if you think about what they do in, breast implant surgery, they're cutting through the skin, they're cutting through the fascia, they're cutting through the muscles to get the implant, putting the implant in, and then sewing all those layers back closed, and they heal stuck together. So, I mean, both of those surgeries absolutely cause a lot of adhesions affecting the chest. They can adhere to the diaphragm. They can pull into the back, the thoracic part of the spine.
My gosh.
The thing is that no matter how skilled, brilliant, or compassionate your surgeon is, they have an uphill battle. They're going to cause adhesions in most cases because that's how the body heals. And if they only formed exactly where the doctor cut, that would be perfect. But they tend to spread over time. And as they do, they can create more inflammation. Then over the years, that inflammation, my body's inflamed. Let me send in some cross-links, some adhesions to help contain that area. So they tend to grow over time. So they stay the same or grow over time. They don't really dissipate on their own.
So interesting. And I can imagine that certain types of arthritis could actually be adhesions.
Yeah. Certainly arthritis.
So exactly, it's kind of like a domino effect. What would you like our listeners in our last 2 minutes to take home, Larry and Belinda Wurn? What are the most important things that you feel that your safe passages, clear passage? For years I've called you safe passage because for me you were a safe passage, but clear passage. What would you like our listening audience to take home and really focus on about the work that you do?
Well, we want you to get educated. If you have a pain and your doctor says there's nothing there, or I can't see anything, or you need to see a psychologist, or relax. No. If you have a pain, it's real. Pain is not natural. There's a reason for your pain. If it can't be seen and it's not a medical condition, you don't have a disease or some hormonal thing that is easy to test for, adhesions form in all of us, so suspect adhesions. Grab our book, Adhesions, what is it? I've forgotten the subtext on it, but grab our Adhesions book, read it. It's the Body's Hidden Menace. It's very highly illustrated, very easy to read. Grab that. Give us a call, look at our website, see if it makes sense to you. We're not going to try to sell you anything. We're going to try to educate you so that you can go back to your spouse or the person you trust or your physician or your healthcare provider or your body worker and say, what do you think? Does this make sense for me? Is this possibly what's going on? So just get educated so that you can step forward, not in a cloud of just this quandary of being referred from person to doctor to doctor to doctor, and nobody knows what's going on and nobody understands it. Well, there's a reason, because they can't see it. So let's look at this and get educated, because there's a reason for all of that.
Right. And I would suggest that at our website that they're able to watch testimonials of patients, describing at the end of the week what their week of treatment was like and what kind of changes that they experienced themselves for the different conditions.
I remember, Belinda, my first time at your clinic at Clear Passage, I ended up saying, I have to stay another week. I begged you. I said, give me as many hours as you can. You said, I can only do a certain amount a day. I said, why can't we do more? Because it was so helpful. And so I would encourage anybody who has chronic pain, unresolved pain, or any of the conditions that Larry and Belinda have talked about in terms of infertility, bowel obstruction, sexual dysfunction, and any type of adhesion, to really search out Clear Passage. And I want to thank you again from the bottom of my heart. I want to say goodbye to all of our listeners. Thank you once again. I'm so grateful you're all listening. We've got record number of hours that are now being clocked in. And this is Louise Gittleman saying thank you, be well, and we'll see you next time for the First Lady of Nutrition podcast.